Hello, everybody. Happy Sunday. Today, I'm going to be interviewing Dr. Tomas Linkevicius hello, everybody, from Lithuania. So it should be interesting. As you know, he is a master. He's coming on now, so let's wait. Tomas!
Hey, hello, hi.
Hey, good evening.
Yeah, we evening here. Yeah, already. You have morning and we have evening.
Yeah, it's 9 a.m. here. So are you at home? Are you in Lithuania?
Yes. Yeah, I'm home. I just was making a steak and I remember that we have an interview.
Well, I hope you got to eat your steak.
Yeah, no, just a little bit, so.
Good. So I
Yeah.
just wanted to kind of talk about a few topics, some new stuff that you and I are working on, and places can catch you because you're going to be traveling a lot over the next few months.
Yeah,
Let's see if
I'm going to be in, yeah,
Go ahead.
yeah, I'm going to LA in September to make a presentation about MIS Connect abutment.
Mm-hmm.
So there will be like official launch of this tool, and I'm going to present the preliminary data of our study, which we have done, and really impressive results, very good. And also then I'm looking forward to November to our joint course. Yeah.
Yeah.
I'm looking forward to learn from you.
There's
Yeah.
there's nothing I can teach you.
No. Sure. I mean, like all this immediate placement and
Yeah.
designing of guides is really what I would like to, let's say,
Yeah.
improve things. So yeah, I think
Yeah.
it will be a great course. What do you think?
Yeah, I'm excited. So the course that he's talking about, we're doing a course November 1st through the 3rd in Beverly Hills here. I'll post links. There's a link in my bio if you're interested. It's going to be hands-on. We're doing pig jaw every day. I'm going to do a live surgery like Thomas was talking about, fully guided with immediate transmucosal abutments. So all of the topics that he brings up in his book, we'll be discussing and doing live at the course. How's the book going, by the way? I
Yeah, I
see it all
mean,
over the place.
yeah, that's. I mean, I'm so excited. I never expected it. That it's all over the world and people just sending me the messages, thanking. And like so, it's like everywhere. Like yesterday, I received from Costa Rica, Brazil,
Nice.
South Africa, Malaysia, Australia. So it's really going all over the world, and I think will have translations
Oh, nice.
into Chinese, to German. So looks like
Fantastic.
we looks like this topic is really, I mean, really relevant because it's like first love. Yeah, we all
Right.
have a first love. Yeah, so everybody's relating. So we all have bone loss. Like
Right.
so maybe that's why it's so. I mean, every dentist understands this. So that's
Yeah.
maybe the key to the. Initially, it looks like it's a great success of the book. Well, we'll
That's
see how
yeah,
it will go on.
I love one comment I saw. Someone said this will be a Bible of implant dentistry, and I definitely agree with that.
Yeah, like New Testament.
That's that's right. The New Testament of zero bone loss.
Yeah.
So what's interesting with bone loss, and I think that's something that you and I have discussed and we have kind of bonded on is that it's not just one thing, right? Everybody expects that there's one thing. And I think early in my career, I was the same way, thinking there was one thing that could prevent it as well. And some of the things that came with that were, one abutment one time. If you do one abutment one time, will that prevent it? Well, no, it could help, going to prevent it. Do immediate placement, does that prevent it? No. If you do platform switching, does that prevent it? No. If you use a certain implant, does that prevent it? No. And so I think it's such a multifactorial problem that people then give up. Would you agree?
Yeah, first of all, I mean, the first thing that we would need to understand this is what you are right. It's a multifactorial thing, but people usually say that there are a lot of factors. This is what you just said, in order to give up. I mean,
yeah.
Okay, so there are so many factors that we cannot control it.
Right.
And okay, so let's accept this 1 millimeter of bone loss. Anyway, usually implants do not fail.
Right.
Okay, so but the fact is that we can control those factors, and it's not that difficult to do that. It's implant design, tissue thickness, and then how do you restore it? So like 3 big branches with small, let's say, factors inside. But generally speaking, I mean, it's really, I think for me, it doesn't look difficult. Of course, not in all the cases. Of course, we have different things, but generally speaking, you can control it. And I would say start, because people say, okay, you talk just about tissue thickness. No, that was the beginning. That was the beginning. I mean, we started from this.
Mm-hmm.
But I say always, first thing you need to know your implant. So what kind of implant you are using? Let's say implant, bone level implant and tissue level implants, different things.
Right.
And they should be placed differently.
Yep.
They should be restored differently.
Mm-hmm.
And so you cannot treat them as the same. And if you do, so that's the first, let's say, the first mistake, and you're starting to have bone loss in the beginning.
Yeah.
So I think that it's multifactorial, but in a good way. I mean, not in this way that we give up, we raise our hands and say, okay, I tried, but it doesn't work. No, it's really possible to achieve it.
Yeah, and I think you brought up a good point as well, in that restoring it and placing it have to be thought of in the same realm. I think so many restorative doctors that don't place implants, they think all the blame goes back to the surgeon. And when I started looking at this years ago, and I'm sure when you started doing your research almost a decade ago, I think, I started realizing how it's almost, and it's hard to say this, but it's almost more important what's done on the prosthetic side. There's certain factors on the implant side, right? There's, let's say tissue thickness, how deep you place it, flap reflection, all of that. Implant design, where you put the micro gap. After that, so much responsibility goes to the restorative doctor. And I think the problem with this is most restorative doctors have very little implant training, and they try to treat implants just like teeth.
Yeah, start to cement first of all.
Yeah, exactly. Exactly. They say, well, I cement all of my regular crowns, so I'm going to cement all of my implant crowns. Well, what cement do you use? Well, whatever cement I use for my teeth. It's kind of the same thing. It looks like a prep. It's just made of titanium, or it's made of some white material.
Yeah. So you are right that from surgical point of view, so it's not that much. I mean, you just know what kind of implant you're using, how deep you place it. Then you, of course, must take care of tissue thickness.
Right.
Of course, we don't even talk about bone. Yeah, that the bone should be there. I mean,
Yeah,
we consider
it's
it as
implied.
yeah, because people say, okay, so what about bone? Of course.
Yeah.
So it's, you know, we need bone, and it was sufficient according to all the rules.
Right.
But from prosthetic point of view, especially now when we talk about subcrestal implants, that when implants are placed deeper in order to accommodate, let's say, tissue thickness to increase it, then it becomes even more responsibility for prosthetic doctor, because let's say simple thing, the height of thigh base, you can so destroy your bone. I mean, you can have so huge resorption because you're pressing too much bone with that poorly selected component.
Right.
And again, what kind of material is it? Zirconia, titanium, ceramics. So index thigh bases, non-index thigh bases. So I would agree that from prosthetic point of view, you have, let's say, much more choices and much more possibility to make a mistake compared to the surgical part.
Yeah, and I think when I've been, you know, traveling around and teaching some of these concepts, I hear if people say, if they hear me talk about implant bone loss, they always say, well, I'm just a restorative doctor. I'm just a prosthodontist, or I'm just a general dentist. You know, why do I need to know about that? Because if a problem happens, they usually send it back to the surgeon and say, you know, your problem.
Yeah, but I think that's changing already. Yeah, maybe in US you have different, let's say, point of view, more how to say surgical and restorative.
Right, we like a referral-based system. We say.
Yeah, but I know that's still changing already. I mean, in US and at the end of the day, I mean, you are one who are responsible for the patient.
Yeah.
And but this is why I also mentioned in my book that you know, I think, you know, the best things work in one hand. I mean, in your hands, then you place and restore.
Right.
But of course, you can do referrals.
Yeah.
But then your surgeon and you must really
be on the same
way.
Yeah, exactly.
Think on the same level, because then it's, you know, really impossible to achieve zero bone loss if you don't agree with the surgeon. You don't know what he is doing, and the surgeon doesn't know how you are restoring. So it should be, I think, should be a team, like, you know.
Yeah.
Like
someone's asking where you can get the book, and it's through Quintessence. So where's the best place online or for them to get it?
In US, I mean, it's Quintessence or Amazon. It also has.
Oh, it's on Amazon. Okay.
Yeah, it's on Amazon as well. So it's in Europe, it's from Germany. It's also Quintessence on the German side.
Okay.
Of that.
So what research do you think is missing? Oh, the name of the book is called Zero Bone Loss, by the way. He's asking.
Concepts,
yeah, Zero Bone Loss Concepts. What research do you think is missing right now?
That's a good question.
Or maybe we shouldn't say it out loud, because that's what we should be doing next.
No. I mean, it's you know, it's so I'm so always, you know, open talking about this, that it's really difficult to do a good research. So
yeah.
I'm not really afraid.
Not worried, yeah.
That. So I have I mean, in my point of view, one of the questions which I would like to answer, and I think we'll construct some study in the future regarding, let's say, if from implant design, because when we look at the microgap from 2 points of view. One is the source of bacteria, because there's always bacteria inside the implant and they start to leak from there. And the other is the stability. So how stable is connection. So current literature says that if you, let's say, have implant without platinum switching, it means that your bacteria is close to the bone.
To the bone.
Yeah, and if you submerge this kind of implant at the bone level or below the bone level, you will have bone loss because bacteria anyway, they will start to leak and you will have bone resorption. Again, doesn't matter what kind of tissue thickness, because this factor then becomes relevant.
Yeah.
So my point of view is, what is, let's say, I don't know, maybe again, this not a good question to ask, which is more important, because I say that you cannot ask a question like this, but I would love to do a research that to have implant without lateral switching with a really stable connection, and then submerge it below the bone, because if the connection is stable, there should not be bone loss related to the movement of abutment. Because we have a lot of implants, with stable connection.
Yeah.
If they are below the bone, the bone does not resorb. So that's maybe like interesting part for me to really understand this, because now we say that's really equal. I mean, that is important. Bacteria important, and also connection stability is important.
Yeah, I think for me, one question that I have that I would love to do research on, and maybe this is something we can do together, is flossing.
Oh, yeah. So we don't floss implants, I don't know for how many years, and we don't even probe them. I mean, that's a great topic. I mean, we could really work something out, because it is,
Because for me, once I started to learn the biology, which I think is very important, that many people need to understand, of implant attachment, and where there's fibroblasts and where there's not fibroblasts, and where there's epithelial attachment, and what kind of epithelial attachment it is. Once I started learning that, I started telling my patients not to floss around implants subgingivally. Maybe if they wanted to go, super gingivally, that's fine with like super floss. And I had them only use water pick and maybe a manual toothbrush, or maybe a electric toothbrush. And when I would tell people that at my lectures, I said, I have no research on this, but it's just my intuition from understanding the biology, they would think that I was crazy.
So I completely agree with you, and we can really work something out, because what we're really talking about is a paradigm shift.
Yeah.
In terms of, we all been told, that you need not even floss. We're talking about probing.
Right.
You need to probe around implants.
Yeah. We don't. I tell my hygienist not to.
Yeah, no. I mean, if there is no problem, if you have X-ray with bone stability, why do you need to do that? Right. So I have a very nice picture in the book, and I also show it. It's from the video, actually, during the lectures. When there was one clinical situation when we had an implant, and we had some abutment, and some tissues were glued to the abutment. And we removed the implant because it was not integrated. Okay. And then we unscrewed the abutment, and when we removed it, and part of which where the tissues were touching the abutment was clean, and the other part was infected, like a dirty area. Yeah. So you have clean zone and you have adherent zone, and the plaque zone. A clean zone, adherent zone, and the plaque zone. Right. So what does the tissue do? It really glues to the surface, and by flossing or by probing, you will start to push the bacteria deeper, and you don't really need to do that. Yeah. And creating a pocket and pushing bacteria deeper. Yeah, exactly. So we don't really. What we recommend our patients to use interdental floss, just interdentally, not to do that. Subgingivally. But what I think from where it came, because the past, there always was metal ceramic crowns.
Right.
Yeah, and you always had glaze below the
Yeah.
tissues, and there was never a proper adherence. The
Yeah.
tissues were not really gluing to that.
Right.
That is why people were
So you had a
really
pocket.
able, yeah, and they were able to floss, because if you have polished zirconia and the tissues are glued to it, so you need to damage the tissues in order to floss below the gingiva.
Yeah.
So it's yeah. But you know, so the current literature says to do us, but this is where it came from. It came from initially not stable situation, and now since we have zirconia and different prosthetic materials, so that should be really change. And I'm also writing about this in the book, that you know,
Yeah.
how should we do that without probing?
Good. I'm glad you agree.
Yeah, sure. 100%.
Someone asked the question, what do you think about muco-integration? And I think both of us would agree with this. This is it's a nice name for it too.
Nice name, exactly.
Yeah.
I really like it. It's really says what it is. It's an integration of the tissues, of the soft tissues, to whatever is on the implant. Is it abutment? Is it retained? Is it multi-unit? But the name is, I really like it. Really good.
Yeah, I think what's important that everybody understands is that it's not as strong of an attachment like you have on natural teeth. So like Thomas was just saying, if you probe, you break that attachment. If you floss, you can break that attachment. With cement, you can break that attachment. And when you break that attachment, if you don't have attachment, you have a pocket. And if you have a pocket, you generally lose bone. So maintaining that muco-integration is so important over the long term.
So I suggest colleagues to look at it as a glue.
Yeah.
Like a gluing. When you glue something together, I mean, it stays. But if you use some force like probing, flossing, or some external thing like cement, or apply a lot of pressure, then this glue may break.
Yeah.
And actually, it is. I mean, muco-integration really relies on epithelial adhesion. And when you look at epithelium, the first line of defense, it's actually glue. It's the hemidesmosomes, they have proteins, and with proteins, they glue to the surface. So actually, it's really, how to say, human glue, which really allows to keep it.
Yeah. Yeah, and how I explain it in my courses is that the body wants to protect itself from the inside of the mouth. So you have that body envelope, and it's going to go and it's going to try to find a material that it likes and a material that's clean. So if it's going to glaze or porcelain, it's going to say no. Then it's going to go down. If it's on something else, no. If the first time it attaches is on the implant, you've already lost, 3 to 4 millimeters because of the biologic width.
Yeah, exactly. I agree with that completely.
Yeah. So you're speaking also at the European Academy of Osseointegration.
Yeah,
right?
That's where you speak as well. So we will
be there.
A lot of meetings this fall.
Yeah, you'll see me a few times every month, I think.
Like every month.
Yeah. So at the EAO, what's your topic?
So at EAO, I will be speaking in Straumann Forum. So we'll talk about, again, we will going to show a clinical study with BLX, because we are our team is a part of the scientists who really make research on this. So,
and what were you testing?
Yeah, so I will be talking with my colleague Algirdas. He will show surgical part. I will won't talk about prosthetic, but it will be about immediate, also really nice topic, immediate placement that in anterior teeth, and after extraction, you place the implant, then you graft and the provisional, all this, what is to preserve, not to allow to collapse, but to preserve the tissues. Yeah. So this will be our topic in there. I also will have some, let's say, my younger colleagues who will talk about in scientific sessions. So one of them will be, we will discussing about MIS Connect abutment. So that will be also very nice. Again, first presentation of the study which we're doing. And also another colleague will talk about the position of the microgap and its relation to the bone level and how does it affect bone stability. So we will again show different groups. In one group we had implant placed supracrestally in order to isolate the microgap, and in another group we had implant placed below the bone. So we will show, I mean, what kind of differences you can expect according to the position of the implant. So it will be really intense meeting. What about you? What will be your topic?
So it's kind of nice. I don't have to speak. I'm just going as a guest this time, which is great. Okay. I never get to go anywhere just as a guest.
So just like for the party, yeah?
Yeah. So the reason why is because I'm the American ambassador for the EAO. So we have an ambassador meeting there discussing how we can expose other territories of the world to this really great meeting. So it's exciting for me because many of my friends, colleagues will be there, but I don't have to speak, which is nice. I just get to go and
you don't need to work.
Yeah.
Like a holiday.
Yeah, so it'll be nice that I get to, you know, of course, any long plane flight for me means reading research, making my lectures better, making my transitions better.
So it means you are looking forward to it, yeah?
Yeah, well, it's quiet time, you know, with having, you know, having a family, having kids, an office, lecturing. When I can have this quiet time, I get so much work done in a very short amount of time. Oh, someone just bought the book. Delphine, fantastic.
Okay, great.
I love to hear that. An interesting thing, I think that that we've talked about a little bit before is if you're cementing tie base or even a full tie abutment outside of the mouth in the lab, cementing that and still having a cement like layer that's non-visible. How are you preventing that and polishing that and all of those different aspects? I think that's kind of it brings in that third person that also needs to know about these concepts, which is the lab technician.
Yeah, exactly. I mean, it's, since we are not cementing, I mean, you are right, it's a tie-base restoration. It's a completely, again, different approach, meaning that lab technician is involved in, how to say, finalization, final step of the prosthesis.
Yeah.
And I guarantee you, if you would ask like any colleague, so what kind of cement your lab uses
they don't
for
know.
gluing, they don't know. I mean, it's 9 out of 10 people say, well, I don't know. Yeah, I trust him.
Right.
Maybe that's the way it should be. Of course, you need.
We should. That's how it should be.
Yeah, trust the lab, but anyway, there are some important things that lab would know. So what research we just published in Journal of Prosthetic Dentistry, it was about the influence of sandblasting on the retention of the
very interesting, very interesting and surprising.
Yeah, that's that's a long story of the research, because we did it 5 years ago. It's really an old research.
Yeah.
Because we didn't have, how to say, it somehow ended up in the like forgotten. I don't know.
Yeah, I've had research like that before.
Yeah, and so last year I said, okay, we need to publish it. So because there was again practice to sandblast abutments, like technicians were doing it like, you know, all the time. But again, very similar to teeth, it happened here that tie base is not abutment.
Right.
It's a tie base, because when you look at it, it all has this incorporated undercuts. Why? Because then it's compensating the height. So the tie base is made shorter for aesthetical reasons, and then they all have these undercuts. Any kind of tie base, if you look at it.
Yeah.
So and when you sandblast it, you really are destroying these undercuts. And you are reducing actually the strength of the gluing. Additional factor is that when you sandblast the metal, small particles of the sand, they stay inside. Even if you put it to ultrasonic bath, and even if you clean it, that stays inside, which further precludes gluing or adhesion. So I was so surprised with the results that I rerun the study. I mean, it's not written, it's not written in the paper, of course, I mean, which is published. But the story behind this, that we did like preliminary tests, and I was just expecting the same, that the sandblasting would increase the retention. And it didn't. So I said, hey, guys, I mean, we're doing something wrong, maybe, you know. Again, so we repeated it, and then I looked in the literature that we were not the first to report this. There was previous several studies showing the same, that sandblasting really reduces the retention of crown on the abutment. So that's like, as I said, we did it 5 years ago, and for 5 years I didn't have any dissemination of any restoration from tie base. So this how to say, protocol we're using like for many years without any problems.
I'm actually going to be bringing my lab technician to our course, so to get him on the same page, because right now I'm explaining everything step by step, but I think having him in the course is really important. And I think that the best lab technicians are the ones that understand surgery, understand prosthetics, understand biology. And it's kind of like the same with implantologists. You know, some of the best implantologists that I know, you have like Eric Van Doren, Iñaki Gambarina. They understand everything. They understand the lab side, the prosthetic side, the surgical side. Even if they don't do everything, these are like the top people because of their understanding of the whole circle of dental implants.
If we started to talk about technical work, so it's another very important topic, the polishing of zirconia. So how it's polished. I mean, it's completely laboratory work. I mean, how smooth it is. And what we have, again, we have developed a really reliable protocol to how to smoothen the zirconia to the smoothness you want. Because, I mean, if you now would ask the technician, so how do you polish? So he polishes something, does something. And I say, okay, so how smooth it is? Well, I don't know. I mean, it looks
shiny.
Smooth. Shines. Shines. Okay, so that's mirror-like something. So again, all these things have the numbers, and then so we have a protocol, 5 steps. Each step can have a certain smoothness, and then you can choose on what you believe, because again, there is a different points of view. Some people say that you don't need super smooth, ultra polished, because then it's too smooth.
It'll fall off, right?
I don't know what will fall off, but the cell will slip, and and others say, okay, let's keep a little bit rougher. So again, up to you. I mean, you can decide for yourself. The lab can decide. It's say, I want this to be that kind of smoothness. and you just, let's say, do not take the final polisher. And so you know that you will be in this, let's say, area of between that number and that number.
Mm-hmm.
So I think it's even more important than, than really gluing to the tie base, because when everybody is using zirconia, and
Right.
And how smooth it is, you can really have better results if the polishing is done correctly than say no polishing.
Yeah. Yeah, I think it's so important understanding the biology, getting your whole team involved with these concepts, whether your whole team is just you or whether your whole team is 3 people or 2 people. I think the difficult part with implant dentistry is that if one aspect is not done correctly, the whole thing can fail. It's like if, let's say you have the perfect implant placement, you have the perfect restoration, but the restoration isn't clean.
Yeah. So,
or like we said before, perfect restoration, but then your hygienist or another dentist or you probe around it. Now you're introducing new bacteria and creating bone loss.
Yeah, that's yeah, you are right, and that is why people tend to give up again.
Yeah.
So not only understanding factors, but you have different people working in, and say, okay, I mean, it's not possible to control everything.
Yeah.
It is possible. I mean, and
it's not easy. It takes some work.
takes like 10 years.
Yeah.
Like a decade.
Someone's asking about composite crowns on hybrid tie-base abutments as a permanent solution. What do you think about that?
So I would say that it is good as a, let's say, long-term provisional solution. Mm-hmm. Because composite, I mean, it's always good in the beginning. It's like comparing composite to porcelain, to veneers. You have, like, we all know that it's, porcelain veneers are better than the composite veneers from aesthetical point of view, from hygienic point of view, and longevity. So I kind of draw parallel here, because with time, composite ages, and it really is not as smooth as other materials. And also another issue, that if we compare, let's say, composite with a zirconia, zirconia is the only material which attracts the least plaque. I mean,
right.
It's not electrically charged enough, so for some reason plaque, that bacteria do not really glue to the surface. Mm-hmm. And that's why it's really unique in that point of view. So this is how a combined, let's say, polished zirconia, in my opinion, from these 2 points of things, is the best material to be placed below the gingiva. Yeah. If the composite crown stays above the, like a crown, not going below the tissues, I mean, till it doesn't break, it can stay. I don't think.
I would say there is an advantage to composite crowns in one aspect, and that would be that the force distribution, and we did a study on this with Pascal Magnier.
Oh yeah,
you can recreate similar dampening forces to the PDL. So that came from our group at USC, and that is one good aspect. Maybe less force going down into the implant and actually going through the tooth, creating how a natural tooth moves. So I think with that, you have to balance the biology and the physics. So in this case, composite would be good for the physics aspect of it, but it may not be good for the biology. Now, like Thomas said, if it's above the gingiva,
I think it's I think it's
okay.
Fine. I mean, it still doesn't break; it wears, so it can be like this.
Yeah, and I've seen some problems, especially with, and I can't remember if I mentioned this in our last interview. I've seen some problems with CEREC users, because CEREC users, they used to only make very short tie bases, and then people would mill Emax. So for example, you would have like a 1 millimeter tie base and then a full Emax crown. And I had some of the
Great.
implant company reps come to me and say, from different implant companies and say, the CEREC users are saying that our implants all lose bone and all of our implants have peri-implantitis. And so I said, well, have them send me some x-rays. And I looked at the x-rays, and the big reason is because the tie base is so short, you're pushing on the bone. Also, you have Emax going almost all the way down to the implant. So of course, the implant's going to lose 2 to 3 millimeters. And that's not even taking into account, what if we started with thin tissue? Or what if the material was dirty? I mean, there's so many different aspects, but you start, we say in the US, behind the 8 ball, like when you're playing pool. You start behind the 8 ball when you have a short tie base and a non-biologic material going all the way down to the implant.
Yeah, so short tie base means that the technician has no other choice but to start the restoration profile very deep.
Yeah.
So, and if you are retaining it, let's say implant was placed a little bit deeper, so you will lose all the bone which is above the implant, that's for sure.
Yeah.
And you can compress the bone, and the problem with compression is that you cannot control it. Some people are resistant to compression. And in some, the bone can, you can lose the implant just because of it.
Mm-hmm.
And of course, another reason is Emax, because, but not just Emax. Kyle, just think, what is the final stage of Emax restoration? They do what?
Glaze.
They glaze. And what is glaze?
Yeah.
Glaze is the worst material.
Right.
Because Emax, lithium disilicate, as ceramics is better because it's dense.
Yeah.
It's denser. It can really, we did a study. It's still not published, that we were polishing Emax, and from terms of the smoothness, it's just like twice rougher than zirconia.
Mm-hmm.
So zirconia, Emax, and then titanium, if we rank them in the smoothness. But what people do, final stage, they glaze all Emax. It means that you have ceramic, feldspathic ceramic, and that's the worst thing you are doing.
Right, you have a pocket.
That's why it's really not implant related. It's related to the lack of the choice of the tie bases height, and also not really understanding that materials which are below. I have a lecture. It's called supragingival and subgingival materials.
Mm-hmm. Yeah, that's nice.
Because this is how we should look at it.
True.
Some qualities are needed what is below the tissue, and some qualities are needed what is above. That was the question about the composite.
Yeah.
So again, in implants, in materials, we need some qualities below the bone and some below the gingiva, and some qualities above. And they might be different.
Yeah, I think people oftentimes will say, porcelain looks really nice, so we should do the whole restoration in porcelain. And it's true, porcelain does look nice. So you have positives and negatives of every material. Porcelain looks great, but it may not be as strong, and it's not great subgingivally. And then you have zirconia, which is strong, is great biologically, but sometimes doesn't look as nice. It's too opaque. And you have titanium, of course, doesn't look as nice, is good biologically, is great for a stable connection. I have a question for you. Have you ever had a zirconia abutment break in an implant that is bigger than 4 point something?
You mean zirconia abutment with the tie base, or
no, all of it full zirconia?
So I had a breakage, but it was 10 years something ago. And since that, I'm not really using full zirconia with zirconia index, the abutments. So I'm using like with tie bases.
Yeah, so I've been using tie bases also
What
for
is
a
your,
long time.
yeah.
But originally, when I first got out of school 10 years ago, I was using full zirconia.
Yes, yes, yes.
And I've only
Oh,
had, I think, 3 fractures, but they've all been narrow abutments.
yeah, yeah, like
So even in
3.3
the larger
centimeters.
abutments, even posterior, if it's like 4.3 or higher, I haven't had a breakage, but I have had a few. I think it's 3 on anterior teeth and premolars with more narrow abutments.
So that should be, you were using probably Nobel or
I
Straumann,
was, yeah, yeah.
because
Oh, you cut out. Oh, you're back. Sorry, you
no,
were
no,
saying
I'm here.
what?
Yeah, yeah.
You were saying I was using
I was, yeah, I was saying that probably you were using Nobel
mm-hmm.
abutments, yeah,
Yeah,
Procera. So they were really, I mean, they're really good.
yeah, yeah, yeah. I think that's true, and I think it just has to do with the thickness of the zirconia. You know, as soon as I had a few fractures, and they all came within a year, that's when I immediately went to tie bases and have been teaching that ever since.
So did you have any problems with tie bases? Because people are, some still afraid to use them, but
I have
I
had the
didn't.
the only problem, let's say problems that I've had 3, same thing, my magic number, 3 uh, times where the cement has come loose from the tie base.
Yeah, these are the cementations.
Yep. And this was early using tie bases because, again, I wasn't informing my labs what to use. And it actually came from 3 different labs, which is interesting,
Mhm.
right?
So do
So
you remember those who were sandblasted or not?
I think all of them were sandblasted.
Because that was the protocol. Yeah,
Yes.
yeah. So that might be the reason for
Yeah.
this, because the undercuts were reduced,
Or reduced. Yeah.
and yeah, and then you just have more freedom.
Right. Yeah. And we had an interesting case recently, and it's a case I'm going to post soon, where I had done an immediate implant on a patient as a 3.5. We had 4 or 5 years of success with it. She came back and wanted to redo her whole mouth. So my partner, Matt Najad, was working on doing that. When he removed the implant, it was a lateral incisor. When he removed the abutment was actually broken inside the implant.
Yes.
But what was so interesting is that it broke, but it was still tight. It wasn't moving, and she didn't lose any bone.
Mm-hmm.
So it was like,
because it was not moving. Yeah, it was
yeah,
stable because of that. Yeah.
yeah. So I think she maintained the mucointegration on the abutment, and it shows how you can have fractures or problems, but still maintain bone, which was kind of a nice case.
Yeah, I agree. Sometimes it's difficult. You have a complication, and then it's really no complication to the bone.
Right.
But here is, I think, it's the stability. Does it really move something?
Yeah.
The closer to the bone, the more it must be stable.
Yeah. Yeah. So we've got a few more minutes. I definitely want to mention again to everybody that Tomas is going to be at the EAO in Lisbon at the end of September. At the beginning of September, he's going to be in LA. Excuse me, giving I think it's a half-day course, right?
Yeah, it will be really a lectures, like two lectures about 2 half-day about the. Of course, I'll talk about zero bone loss concepts.
Yeah.
But let's say the strength will be introducing and showing our research how to maintain, how to really not to have bone loss and not even bone remodeling, because that's now possible really to have completely bone do not react to the
Mm-hmm.
to any work which we were doing.
Yeah. So that is the first weekend of September. And then we have our course, yes, we have our course coming up the first weekend in November.
Yeah.
And that's going to be, I'm excited. It's 3 days. We're doing a day of prosthetics
Yes.
with pig jaw, a day of surgical with pig jaw, and then a day of more digital and immediate placement. So you'll get a good amount. And so I encourage you, whether you're a lab technician, whether you're a restorative doctor, whether you're a surgeon, whether you do everything, you will learn a good amount. And I am excited to go as a student for the first 2 days. And then I guess
and then we change.
Yeah, then we change. Then you're the student and I'm the teacher.
Yeah, I think it will be really exciting, because then we will really able to see how to apply zero bone loss concepts in immediate placement.
Yeah.
Because that's really a new topic.
Mm-hmm.
To be able to control, because one thing I will talk about healed ridges, that when the ridge is healed, what to do, I mean, how to develop and to maintain bone stability.
Yeah.
But when you have immediate, so that's completely different.
Right. You're
so
dealing with bundle bone being lost. You're dealing with a new blood clot.
Yes, you have like a big extraction socket and things like that. So we will see how we can really apply what we have learned in first 2 days directly at the third day.
Yeah.
So will be like a dessert.
Yeah. And then I think at the end, I mean, you and I are both still constantly learning, constantly trying to improve. And so at the end of this course, we can really have maybe not a consensus, but maybe a time where we can sit and talk with the participants and think of some ideas and maybe where we need to go, what we still need to learn.
Yeah, that will be nice. I think that's what really to be in we can really make some conclusions. And but I always encourage the participants of the course to share their experience.
Exactly.
And, to because I'm gonna show my failures. I'm sure you will show, because it's we are not immune to complications. And I created this zero bone loss because of my complications, not because of
your successes.
Yeah, exactly.
Yeah, exactly. So one last question, and then we'll call it. Someone said, what kind of cement do you recommend your labs to use?
So we did a research, and currently, and for 5 years, and we didn't change. I am using GC Link Ace cement. I mean, it's just I have no connection to the company. I'm just saying that this was cement which was the most the strongest. And when I really looked into it, I found that it really has monomers, and it really has a good possibility to set in an anaerobic situation.
Nice.
Also was
and is all of that in the book?
Yeah, it's written there. Yeah.
Fantastic. So you can get that in this book, Zero Bone Loss Concepts Through Quintessence. And Thomas, I thank you for taking the time out of your Sunday evening.
Yeah, now I'm very hungry and go back to
back to your steak,
which is cold now probably.
Yeah, that's right. Yeah. It definitely
I will have to heat it up.
That's a big
sacrifice.
Very big sacrifice. So everybody should be thankful that he sacrificed his dinner to teach.
Thank you for organizing this. Yeah, great. Thanks.
Sure. Okay. Always good talking to you, and see you in a few weeks.
Yeah. Okay. Bye-bye.
Okay. Ciao. Bye.